I'd like to welcome everybody to today's webinar, Advanced Payment Models, an overview of what we feel you need to know. My name's Scott Mash. As always, I'm joined by Miss Cathy Costello. Now in this webinar, we do kind of refer to some of the meaningful use measures, stage 2, stage 3. If you need a quick refresher on what those requirements are for those measures, there's a link to a recording of our session from the 2015-2017 Meaningful Use Final Rule that included all those stage 2 and stage 3 requirements. Before we roll into APM, we want to do a real brief overview of MIPS because some of those APM providers are still subject to MIPS. But at any rate, your timelines and meaningful use, or what's called ACI measures under MACRA for the 2017 reporting period. If you are in the MIPS program, you're going to have a 90-day reporting period. You're going to attest under the ACI or report to either stage 2 or stage 3. Now, if you are in the MIPS program and you are a provider who still has some cash left in the Medicaid incentive program, you're going to have to report twice because you're going to have to report under the Medicare program for MACRA and under Medicaid as well. Don't forget, Medicaid is going to have a 90 days. This is traditional meaningful use. You can do stage 2 or stage 3, and again, this is going to be a separate reporting. So you may have some providers that are going to have to report twice. Hospitals in 2017, you are also going to have a 90-day reporting period. It's a modified stage 2, stage 3 without CPOE and CDS, and you only have 3 public health reporting measures or specialty reporting. So let's talk a little bit about MIPS eligibility. I'm actually going to skip ahead to this next slide and do it all in one slide. When you are preparing, you're sorting your list of providers, trying to figure out how in the world you got to report and who you're reporting for. First, look towards your exclusions. Look to see if your providers meet the low volume threshold. Now, CMS is supposed to tell you who those are, but the way the threshold works is do you have less than 100 unique Medicare patients or less than $30,000 in Medicare Part B billing in a given time frame, which you can find in one of our earlier slide decks. If you meet either one of those, you meet A or B, then you're excluded. If you have a provider who is brand new, they're just out of residency, they are excluded for that calendar year that they start with the organization. If you think back to meaningful use, you kind of got a 2-year pass. This year, under MACRA, you really only get a partial year pass. So if they were brand new to your organization in 2016, you roll over to 2017, they have to report for the 2017 reporting period. Also, if you are a QP or partial QP, that just means are you in some alternative payment model that meets the requirements, then you are also excluded from MIPS reporting. Then you look towards your category provider to determine if you're in an APM or an advanced APM. If you're in an advanced APM, you're getting a plus 5%. All other APMs, you don't get the bonus, but there may not be a dual reporting requirement. Cathy's going to go into a lot more detail on that here real soon. Then once you figured out who you got to report for, if you're MIPS or APM or AAPM, how in the world are you going to report? Now, I'm going to tell you up front, when we get into this, we can tell you from a high level, the means by which you can report, but there's still a lot of gray area. There's still a lot of detail that the data registries and CMS is going to have to fill us in. We are going to talk a lot about data registries because we're big believers in data registries and what they can do for you. So again, looking at the rewards and penalties, the carrot and stick under MACRA. For the 2017 reporting year, we will have, in 2019, you will either receive an incentive, a penalty, which is an up and down 4% swing. If you're one of the best, you may get up to a 14%. If you're in a recognized advanced APM, you automatically get a plus 5%. Now, I want you to keep in mind, you see plus 4 and minus 4, and then you see that big jump up to 14. This is a budget neutral program. It is going to be a difficult program because to have a winner, you got to have a loser with budget neutral. So kind of keep that in mind as we move through. With that, I'm going to turn it over to Ms. Cathy.
Thanks, Scott. One thing I'd say about this slide before we hop off of it, though, just to kind of set your sights for 2017, if you are not an advanced APM, where you automatically receive the 5% for your qualified professionals, then be aware that CMS has set in writing their guidelines for what would put you into that maximum bonus category for exceptional performance. And what they're saying is that your composite performance score under MIPS, so CPS, where you take all these areas, your cost, quality, improvement, practice improvement, and meaningful use or ACI, and roll it into one score. If it's 70 or above, they consider that to be exceptional. And that would include if you're reporting as a group. So you can kind of set that as your goal for next year. All payment adjustments flow back to the TIN NPI, whether or not you're part of an advanced payment model or not. So you may end up reporting certain things together. You may get judged together because APMs have assigned the same composite performance score, or CMS assigns the same composite performance score for all members of the APM. But when it comes time to reward or penalize, it's done at the TIN level for members. Okay, so what is this APM? How do we get there? What groups are covered by it? What you see on this slide are all the various programs that fall under the CMMI, which is the Innovation Institute for CMS. And it's basically where they put out all their new pilots for payment reform and for some specific targeted workflow or chronic management type of programs. But all the new payment reform flows through here. And so they have over 15 models right now. But of those, only 5 come into play when you're talking about alternative payment models that fall into the MIPS categories, or into the MIPS identified as APM. One of them is the CPC Plus. One is the Shared Savings Program, MSSP ACO. Whether you're track 1, track 2, or track 3, you fall into this MIPS-APM at different points. The other ACO that's commonly referred to as the Next Generation ACO, it is also part of this. End-stage renal disease, ESRD model. There are 3 different models, risk-bearing and non-risk-bearing. They're all in this program. And the oncology care model, or OCM, is the last one. Each of them may have slightly different requirements. We'll try to point those out as we go on. But let me just say, to set the stage before we get into the details, I just find it amusing. I'm sure we're all very amused by 5,000 pages of regulations. But if you have to laugh over something, I've got to tell you about my little dialogue back and forth with CMS, because as we were preparing for the APM webinars, you know, I kept going back and reading and rereading certain sections and going, this makes absolutely no sense. There is no way that you could put together the MIPS model with the APM model, have them flow together and make sense. And I thought, I must be missing something. But it looks like what happened was one person or one group of people wrote the MIPS part of it, and a different group of people wrote the APM portion, and nobody read the whole thing from one end to the other to see how it all fit together. And I thought, wow, that's being pretty harsh judging CMS that way. You know, let's face it, the final reg was 3 times as long as proposed, and they were probably just overwhelmed. So I started sending up questions to CMS asking for interpretation as to how the APM model fit in with the MIPS model, especially when you get into this partial QP and people who float back and forth between the models. And I got a response this morning, and basically they said, wow, these are really good questions. We don't know what the answer is, so we're going to have to send them up to our program people to figure out how to respond. So keep that in mind, kind of tongue-in-cheek as we go ahead, because I think we're all learning together, including CMS. So as far as bottom line things that we do know about the APM models, there are different levels of models, and they're handled differently in the regs. One of them is called MIPS-APM, and one's called Advanced APMs. And as Scott showed you on that slide with the reimbursement, the difference for you all that are going to have to work, especially with systems, with large number of providers and trying to figure out how this fits in with what you need to do to manage them, you're very interested to see who falls into that advanced APM bucket, because you don't need to do anything else for them, and they get a 5% bonus. But anybody short of that, including ones who don't qualify for the threshold of a QP, you're going to have to do stuff for, and you're going to have to basically earn your incentive. So it's really important to understand which particular payment models fall into which particular category, so you understand what your game plan is going to have to be in 2017. The first level, well, the very first level, it's on a further slide, is non-MIPS, non-advanced. That it's not a MIPS-APM. It may be an alternative payment model that is sponsored by a payer, is sponsored by Medicaid, one of these other things. We'll talk about that a little more in depth, but that would be the first level, no attachment in this reg. And we'll talk about how you handle those providers. MIPS-APMs are those that are part of systems or part of agreements or payment programs with CMS that have three basic requirements. They have to have a written agreement, and as part of that agreement, you have an identified list of practitioners that you submit to CMS. This will play into your reporting and CMS's determination of your providers. So that's where CMS gets their information about who to analyze as to where they fall into advanced payment models. You need to have at least one eligible provider, clinician, in that MIPS-APM. That's usually, especially if you're in a shared savings, is not an issue. The third one, and this is a contractual issue for your organization, but if you're a MIPS-APM, CMS, I'm sure, has made sure that this is found in your contracts with your providers. But your provider needs to be rewarded for performance on cost and quality as part of their involvement in the MIPS-APM. When you're talking about advanced APMs or APMs, these have further additional requirements. You must have certified EHR technology, which is actually true for the MIPS-APMs also. You must have professional services linked to quality, same as MIPS-APM, but the last point is the one that really differentiates a MIPS-APM from an advanced APM. And this is that the MIPS-APM either must bear financial risks. The members, the participants in it must bear financial risks beyond just a nominal amount, or be a Medicaid medical home model. So those are two different avenues that put you at the advanced APM level. We won't worry about what the financial risks are. There's, they had some group of economists who had nothing better to do than to create this model, but there's hundreds of pages related to financial risk and how they calculate it. But basically, you're interested in knowing where your folks are in this set of APM models. The other APMs that we were going to look at are what are called other payer advanced APMs. They may look just like the APMs that you're involved in with Medicare, but because they are not sponsored by Medicare, it's another payer, whether it's Medicaid, whether it's a commercial payer, whatever. These are a different group. They are not recognized in this group of APMs for Medicare until 2019. So this is something that if you have people in a commercial payer APM, you can look forward to 2019 in some type of combined program. There may be other ones that the requirements are going to be similar here. I think when we see the regs that are proposed for 2018 that will come out in the middle of 2017, we'll have a better idea if there's any specific requirements on other payer APMs. Currently, CMS identifies these particular groups as being advanced APMs. These are the ones that will get the automatic 5% adjustment up in pay without any further action, assuming they meet the threshold of patients or billing required by CMS. So these groups are CPC Plus, and that is a medical home model. It's not a financial risk model. Medicare Shared Savings Program, Tracks 2 and Tracks 3. We'll talk about Track 1 in just a second. Next Generation ACO model. Those are all risk-bearing. ESRD, which is the end-stage renal disease programs, and there's actually 3 different models here, of which 2 of them fall into the category of advanced APMs. And those of you who are working with ESRD models will know which one you're in. The last one is the oncology care model, and that is in. The ones that are being proposed and that we will look for in 2018 proposed regs to see what additional requirements they might be are they have 2 episode of care payment models that they're looking at that I'm sure have to do with proposing models that the specialists can take advantage of. Cardiac rehab model, that one should be quite interesting. I'm sure a lot of groups will be interested in seeing if their members can be in a cardiac rehab model. The other one is joint replacement. Your ortho groups are really perking up to see what they would have to do to fall into this. This next one is a very interesting one, and that is the Medicare ACO Track 1. So your shared savings program, those of you who are in ACOs, the vast majority are in Medicare shared savings. These are not risk-bearing models, and because they are not risk-bearing models, Track 1, that is why you're excluded from the advanced APM. But what CMS has stated several times in these regs is that looking ahead to 2018, they are planning to create a new, what I call step and a half, 1.5 MSSP model. So it'd be Track 1 Plus is what CMS is calling it. And it'd be kind of a hybrid model between a complete risk-bearing model and a no risk-bearing model. So it'd be something that would bring the MSSP model into the advanced APM model without assuming the same level of risk that Track 2 and Track 3 have. And again, we'll just have to wait and see how those regs are written. Okay, reporting under these different models changes. The first one, if you're a non-MIPS APM, so if you're one of these other payer APMs, or in Ohio, interestingly, I want you to think of this, in Ohio, the proposed CPC, Ohio Medicaid CPC model that will be opening in 2017 will not be eligible to be APMs in Ohio, in MIPS APMs, because there's no requirement for an EHR system to participate. So there's different reasons, different analyses here, but as we move down the path, within the next year or 2, they're going to take another look at these models. But for this year, for 2017, you will treat people who are contracted under these models exactly as you would as if they are a straight MIPS provider, and you can report for them either individually or as part of group reporting. If you are a MIPS-APM but not an advanced APM, so if you're MSSP, Track 1, you're some of these other alternative payments, you will fall into this MIPS but not advanced APM, and you need to make sure that you're reporting for this group. You consider the group as a whole when you report, and there are concessions to your reporting, or you get bonus points in certain areas, but you absolutely need to make sure you're reporting, because otherwise your members, your clinicians who are part of this will be subject to penalties for a year. If you have physicians who are contracted as part of the shared savings but are not part of that provider list, say they're a specialist that contracts in just to provide, they actually are like vendors for the shared savings program. They're providing certain services, but they're not part of the underlying provider group that is submitted to CMS. Those are going to need to be handled separately. They should be handling themselves, but they need to report. They would not be covered by the shared savings, other than, again, they get bonus points for participation. If you're reporting as a group, you need to report all members of the group. If you're in the advanced APM, again, just to remind everyone, automatic 5%, no further reporting, assuming you meet the thresholds. A reminder on the hospital-based and the specialist, these are all ones, if you're in an advanced payment model, more than likely you will have hospital-based and specialist as part of that, and they are covered. If you need to do reporting and you're doing it as a group, you would include them in the group, and they would participate at the same level as everyone else. We won't go into the requirements for the specialists. We've covered that on all the other webinars, but the information is there if you want to see how your people are categorized and when those determinations are made. Okay, as far as reporting in different APMs, because some people, especially the specialists, this is not so true in the primary care area, but in the specialty area, you will see specialty groups, say ENT or ortho, whatever, may actually participate in more than one APM. If you have different reports, or Scott will talk in a few minutes about what is basically your meaningful use report and your scoring around that. If you have a higher score in one APM than another, and you've reported as a MIPS eligible professional, and in each of these places where that provider shows up under that NPI, they have different meaningful use scores, CMS will credit that provider with the highest of the reporting calculations for meaningful use, or ACI. Okay. This is where it gets really interesting. And this is where, at one time when Scott and I were first looking at these regs a couple of weeks ago, I said, oh my gosh, what were they thinking? Who would read this thing cover to cover other than crazy people like us? And what I ended up determining, I think it was just perverseness on CMS's part. Some of the stuff about definition of QPs are way, 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 way back there in the regs. They're like past page 1500. And I think maybe with a twinkle in their eye, they decided that maybe it'd be good just to see if you read all the way to the back. So we're going to put in stuff that doesn't agree with the front of the reg and the back of the reg. So, but with that being said, I will tell you specifically everything that we have here comes directly out of the reg. We will just point out where there's disagreement with one section or another. QPs, or qualifying participants, refer to providers who are in APMs, and specifically you're trying to determine if they are in advanced APMs. If you are talking about just a MIPS-APM, like your MSSP Track 1 or something like that, those people are not QPs. The only people that you look at when you're trying to determine QPs is in an advanced APM. And then you have to determine if they meet the threshold for reporting or being QPs in that area. And we'll talk about that in just a second. What determines a QP is one of two things. Either under your claims, you meet whatever Medicare's threshold is for that year of Medicare Part B billings, or you meet the unique patient level that CMS has tagged for that year. For example, in 2017, I believe the level for the billing is 25% of all your Medicare Part B claims are processed through the APM. And I don't recall offhand what the patient load is, if it's more than 100, more than 500, whatever it is. But whatever that level is, you need to look at one or the other of those. CMS determines this for you, whether or not your providers are qualified participants, whether they crack that threshold of 25% or unique patients. And once they make that determination, they will let you know that it's supposed to be posted by NPI number so that you have some idea of who actually falls into the QP bucket when you're trying to decide how to report. Their eligibility includes also services furnished as part of CAH's rural health clinics or FQHCs. If you do not meet the definition of a QP and you are part of an advanced APM, then you are what is called a partial QP or partial qualifying participant. And the significance of these people is you will be part of the advanced APM. You will not automatically receive the 5% bonus, but you will not receive penalties if you do no further reporting. But that means that you have no possibility of incentives. So if your entity, your APM entity, needs to make this call for all of its partial qualifying QPs, if you decide, well, you know, maybe it'd be a good thing if we tried to report because our providers could get 4% or maybe up higher than that, maybe all the way to 14%, if they decide to participate on the MIPS side of the reporting picture. And so they decide, okay, we're going to take all our partial QPs and file for them under MIPS so that they are at least eligible for the 4% incentives. So on the one side, QP, you meet the threshold, you're in an advanced APM, you get the automatic 5%. The other side, you're also an advanced APM member, but you don't meet the threshold either by claims or by patient numbers, and you will not receive a penalty if you do nothing else, but you will not receive a bonus unless you, or incentive, unless you actually file under the MIPS track.
Now, that's also not to say that this alternative payment model that you're within may have a separate incentive or penalty against those included
right,
payments.
And that's a good point, because, you know, this again is one place, I had to laugh looking at these rules. Scott and I were like, our eyeballs were falling out after, you know, a week of reading regs, and we still have 3 more weeks beyond that, because when you read all the regs from this year, you're up in the probably 7,000 or 8,000 pages area. And but there is not a lot of
alignment between programs.
That's a good way of saying alignment between the programs, and I will point that out as we go on. But one of the things you need to keep in mind here is whoever wrote this, when CMS designed MIPS, it was a standalone. I mean, they don't take into account what happens over here at the MSSP. I mean, they talk about it, but the reality is everything you do for shared savings or for one of these other advanced payment models, as far as your quality reporting, as far as your payments, as far as your bonuses and your shared savings, that is all separate. This analysis that we're talking about here is strictly for MIPS and QP, and anything else, any additional funding that you might get through being participants to a shared savings program is over and above what we're talking about here. So how and when does CMS decide who's in this advanced APM and who's going to be a QP? And basically, as I said, every single MIPS-APM, whether they're advanced or not, has to submit a list of professionals who are covered by that type of advanced payment model. So CMS knows who to make sure gets paid. And so the underlying list, and the list as you all revise it at each quarter, March, June, and August, CMS takes that specific day at the end of each one of those quarters and looks to see whatever revised list you submitted as part of that program. And they will say anybody who was a member in one of those 4 days, the first time you submit or the end of each quarter, will be counted as part of that APM model, whether it's the MIPS model or whether it's the advanced model. It doesn't matter. That's when they decide. As I said, they will let you know. They will publish that. The oncology care model is the only one that uses a different determination period, and that's January through April, but I think the OCM people are worked with pretty much individually, and you'll know that. Now, this is where we get into some real interesting language where there is no agreement between the MIPS model and the APM model. And for those of you who have asked about it, this is one of those areas that there just isn't agreement. And these are the lines of questions that we sent up to CMS where they're like, wow, is that a good question? You know, we don't know what the answer is, but that was a good question. So I'm going to tell you what the reg says, and then we're going to have to wait for CMS to determine how to interpret it in light of MIPS. Because the reg, in the far back of the reg, says, hey, if you're in an advanced APM, we're going to include, besides our physicians, our nurse practitioners, PAs, podiatrists, and I didn't even put those on, but it does include your chiropractors, podiatrists, optometrists also. But besides all these people, we also think that advanced APM should include physical therapists, occupational therapists, social workers, psychologists, dietitians, speech pathologists, and audiologists. But the interesting thing is that isn't what MIPS says. In the early stages, not for 2017. 2017 is strictly those identified physician categories, as I said, including your chiropractors, podiatrists, and optometrists, and your mid-levels are basically, and dentists is the other one, are those that are included in the MIPS model. But for whatever reason, these regs expand this to this allied model. And what the language says is we think, and I mean, I'm not quoting, but the idea is exactly as it was expressed in the reg. We think that these people should be rewarded under the advanced APM model, that they should participate in the 5%. Well, that's all well and good, but that doesn't tell you whether they also need to meet the threshold models that were developed for advanced APMs. You know, do they do adequate billing? Do they see enough patients who are Medicare Part B? And if not, are they excluded because of low patient volume? I mean, these are all questions to try to reconcile the two programs. Or do they automatically become partial QPs who are then continue to be eligible for incentives, and you just need to file for them? And that is one that is, wow, that was a good question. We'll have to look at it. So I'm just telling you, let's watch and see what happens with this. Okay, now when you're talking about identification, this will drive you crazy because each one of your providers will be identified by numbers that have more than 20 digits to them. And the way they split it out is CMS assigns an APM identifier to your ACO or whatever, your CPC plus or whatever it's going to be. Then they have an entity identifier under that. So if you're, one of 10 hospitals participating, your hospital may have its own entity identifier. Under that, there may be different tax IDs. So those have a different identifier. And then at the very, very bottom is your individual professionals. And they are identified by their NPI, which, as you know, is 10 digits. So the overall identification of each one of your providers runs to about 25 digits. If you are one of the medical home models, and right now the only one that is officially recognized for advanced APM status, well, I shouldn't say the only one, but the one that CMS is pushing, begins at the beginning of 2017, is the CPC Plus model, but there are a few other that fall under medical home models. These have to have primary care practices or be multi-specialty with primary care services offered, and they must impanel patients to a given provider. So those are two required elements to be a medical home model under CMS, and it also requires 4 of the additional 7 listed here. So it's pretty much a PCMH model. Are you doing coordination of care for chronic care? Are you doing continuity of care? Are you risk stratifying? Are you doing medical neighborhood? Are you engaging your patient or their caregivers in their care plan, and you're doing some type of shared decision making or some special payment arrangements? So 4 out of those 7 needs to be present. You do not requisition CMS to be a medical home model. They will tell you which models they are recognizing. Okay, under the quality reporting, and this is kind of an interesting area for the APMs because all of you do quality reporting already. This is the definition of an advanced APM or a MIPS-APM, is that it's a new payment model linked to quality metrics. So every one of you has a certain panel of metrics that you track. Some of them have all required metrics, and some you can select. So CPC Plus has to report on 9 quality metrics out of a total of 14 potential. Shared savings has 34 metrics, of which you have to report on all of them. Some of those are the patient survey satisfaction survey. Some are hospital cost metrics. But basically there are 14 remaining, and we'll see how those fit into your reporting for MIPS. ESRD has 26 measures, including the patient satisfaction survey. And oncology care model has 13. So each one of these programs or each one of these MIPS-APMs already has quality metrics they report on. You do not have to plan on reporting on a different set of metrics, but how these are analyzed is kind of interesting to see what CMS does with it. So let's take the shared savings, because this is probably the model that is most frequently present as an alternative payment model in Ohio. Here are all the metrics that you track for shared savings, all 34 and the buckets that they go into. Starting at the left, you've got your patient satisfaction model or metrics. Next one's, for the most part, the second column is your hospital cost readmission admission figures. Then you get into preventive care, and then the last one's your at-risk population, and those all have their own metrics. This is what you need to report on. Some you get judged on for your shared savings, some you don't, depending on when they were introduced. Let's see how that translates to if you report under the MIPS program. Taking the same metrics, they do a totally different scoring of those metrics for determining whether or not you get an incentive payment under MIPS, because as we said, shared savings is an APM, but it's not an advanced APM if you're track 1. And so it is designated a MIPS-APM where if you are going to have to report. So how are you scored? You're scored differently. They take out all the patient satisfaction survey measures. they take out the hospital admission, readmission figures and quality reporting related to that. Of the remaining, there are 14 measures that you're looking at. Basically, the ones that have check marks, most of them are very common ones for you. It's preventive care, you know, your screening, your tobacco use, your weight, a BMI, flu and pneumonia, stuff like this, mammographies. Those are all calculated as part of your MIPS scoring for quality. There are 3 measures that are not used, although you must report on these as part of your MSSP reporting for the program. But the 3 that are not used to calculate your MIPS score are your documentation of meds in the med list, statin therapy, and your depression remission after 12 months. The reason why is they do not have thresholds for those. Those were new measures for the program. The other 3 that are not used are beta blocker, ACE inhibitor, and blood pressure screen after 2 years or within 2 years. And the reason those are not used is those were newly introduced to the program. You're reporting on it. You're not being judged on your performance, so they're not using that as part of the MIPS scoring for MIPS-APM shared savings. Okay, now we're going to move over to the technology. Scott's going to walk you through this whole business about stage 2 and stage 3, how it is used. Bottom line is, if you are doing MIPS reporting, no matter whether you're just a MIPS professional or you're one of these APMs, if you're not an advanced APM, you have to be doing meaningful use ACI reporting.
Yeah, so as Cathy shared earlier on, if you're an advanced APM, must have a requirement that certified technology be used. In other words, an advanced APM, you got to do meaningful use. Now in 2017, 50% of the eligible clinicians, now it's unclear whether this is the eligible clinician definition under MIPS for 2017 or that expanded definition that is mentioned in the alternative APM model conversation, but 50% of the ECs in each of the entities within the APM must use certified technology. And in 2018, the math changes a little bit. They don't look at 50% within each entity, but 50% overall within the APM. They must, at least 50% must use certified technology. And again, which definition of EC that is? It's a little unclear. I would go with the expanded just to be sure you meet it. Now under the shared savings program, let's skip ahead because this actually, oh, wait a minute. One other point to make here is that if you have an advanced APM that includes a hospital as one of those entities, then all of the hospitals must use this certified technology as well.
Must report.
And must report as well. So with the ACO, the shared savings ACO, currently the
this is an alert here. This is one of those places where the rules do not agree, so you have different requirements. This language comes out of the ACO rule, but we're telling you what you're required to do for ACO reporting versus the MIPS scoring. Okay, so just so everyone's clear and you can see what your needs are.
So in the shared savings program, they do have a quality measure, which is ACO measure 11, and what that really is just the percentage of providers who successfully met meaningful use. Currently in 2016, that only includes primary care providers. Next year, when we get in, it's primary care physicians, just the physicians, not mid-levels.
No,
or is it
I think it's Smiths too.
We'll have to get some clarification on that, but regardless, in 2017, that now includes specialists as well, and also your MPs, your PAs, and your nurse midwives, and you know, so it's going to expand. Now, the reason ACO 11 is so important, why that quality measure is so important, is it carries double the weight of all the other quality measures. So
for your shared savings.
For your shared savings.
Shared savings calculation.
This is
not for MIPS, but for shared savings. We'll look at the weighting for MIPS in just a second.
So in 2017, if you're in MIPS or an APM and you're going to go stage 2, things are a little bit different. The exclusions, the concept of an exclusion under MIPS goes away. It's still there for Medicaid, but it goes away under MIPS. For those items marked in red there in the middle column, you must either say yes or get at least one patient in the numerator for all those items in red, or it doesn't matter how well you did on every other measure because you are going to get a 0 in the ACI score. Not reweighted to 0, but a 0. And those are, of course, you got to do your security review, your ERX, your patient access measure. Again, that's the portal. Are you pushing information to the portal? And then for the electronic transition of care, you got to send out at least one. Now, you want to do better than one. You want to do better than one because if you look in the third column, it tells you the percentage of points, the maximum percentage you can get towards a score of 100. So you want to get as high as possible because if you remember, if you get a 1 in all of the red items, a yes or a 1, that's going to give you 50% of your ACI score. Then the other 50% is made up of how well you did. You can also get a bonus for some of the public health registries over and above the immunization. So if you're doing syndromic or some specialized registry reporting, you're going to get a little bonus. And then there's some CPIA activities that will also give you a bonus in the ACI.
But notice how this differs from what you're doing right now, because right now you're required to do public health reporting. Not under MIPS. You get bonus points for public health reporting, right, but not required. Well, who's going to undo their immunization feed? You know, the idea is you're supposed to keep it up, but you get bonus points for it. The other thing is, notice the electronic summary of care. Right now, you are able to exclude out your providers who have less than 100 referrals or transitions of care during the reporting period. No more. Starting in 2017, you have to have at least one patient for every provider if you report individually or for the group as a whole.
Now, if you're going to take a run at stage 3, the concept is the same. If it's a red item there in the middle column, you got to get 1. The only place it really differs is that that second HIE measure where you have to accept or request the transition of care, the electronic transition of care, the CCDA document. That's really the only difference there with what's required for your base scoring. The calculation for your performance score is a little different because you have a few more measures in there as well. Same concept applies with the immunization. It's one of those things where you don't have to do, but hey, you're crazy if you don't because you get a 10% hit with it. And public health, you get a bonus, and then the CPIA activities count there as well.
And the way that scoring works is, for example, let's say that your patient ed, that you give 86% of your patients education in your meaningful use dashboard. Pretty much, I mean, we'll have to wait until CMS puts the charts out, but pretty much an 86% would weight to 8.6 out of a potential 10 points for that area. So you're trying to add up and just figure out how you're going to rank compared to how you're doing this year. That's what I would do, where each one of those measures equals 10% and just figure out what your total is right now.
So what we recommend with that, when you're setting your goals or you're creating your dashboards or you're working on your communication plan with your providers, just do away with the concept of exclusions. Regardless if they're in Medicaid or not, do not think in the terms of exclusion. Set threshold goals for each of the measures and internally judge or train towards those thresholds. So that way, I mean, quite honestly, there's no reason to not get a near 100% for your performance score. Because if you read through the regulation, there's something like, what, 140 points available to get 100 points?
Yeah,
So,
yeah.
So,
you should be able to move up there pretty easily.
The one place where you're really going to have to work and get that score up as high as possible is with those HIE-related measures, because, those tend to lag a little bit behind. There's no reason to not get a 100% performance score in the ACI category.
Okay, we're going to talk about clinical practice improvement and the whole concept of scoring each of these areas, because you've got your cost, you've got your quality, you've got your improvement, and you've got your meaningful use ACI. So in ACI reporting, who's responsible for reporting? You are responsible for reporting the meaningful use ACI measures for the providers who are in your TIN if they are participating as part of an advanced practice model. The way that CMS weights this or scores it is they'll take all the providers in an advanced practice model, and they'll, for example, say you're a group with 100 providers, and one of the other providers that are participating, or one of the other provider groups only have 10. You report your meaningful use metrics for your 100 providers. They report theirs for their 10. Your weighting will have 10 times the weight as theirs because you have 10 times more providers. And CMS does that calculation on the aggregation and assigns a score for the advanced practice model for all the providers. So their concept, and they went in great detail analyzing this about doing stuff separately or together and yada, yada. And they basically said, hey, if you got together as a business model to improve care in your area, we're going to judge you as a group. And so that's what they're doing, but they're trying to give you the advantage of at least giving a higher score for those of you who have more providers who are participating. As we said, the advantage goes, the score is assigned for everyone in that APM. The composite performance score that is drawn down, it goes to every single provider and every single entity under that APM. If for some reason your shared savings model dissolves halfway through the year, say it ends at their 3-year reporting, decide not to opt up again, then you revert back to the MIPS model and you report everyone the same way you would if they were MIPS providers. You can do it either individually or as a group. If for some reason your ACO or your advanced payment model does not report the quality that they are required to, then each TIN will be judged by their own submission. The CPIA or improvement reporting, you do not have to individually worry about, and I'll show you why here. Clinical practice improvement is assumed by CMS to being done by advanced payment models because they assume you're having to do all these specific workflow areas to be in an APM. So what they have decided to do is they are going to award you, depending on your model, certain points for your clinical practice improvement for participation. And they will do that upfront before any given payment year so that you know how you're being weighted. In this year, all Medicare or MIPS-APMs are going to receive the full bonus points for CPIA, whether you're CPC Plus, Shared Saving, ESRD, Oncology, MSSP, and other tracks, or Next Gen. All these receive full bonus points, and we'll talk about how they get weighted versus the other categories.
And there's no need to even report CPIA
exactly
separately.
No need to report. CMS will just assign it to your group. If you were in a non-MIPS APM, so you're in one of these other payer models that aren't going to be recognized for another year or two, you do get half credit in the CPIA model for participating in an advanced payment model, but only half credit. You will be responsible for putting together the other 20 points to cover your reporting in 2017. The only thing I'd say about the scoring of this is if you have providers who are in more than one model, specifically if your providers, you have a group of providers within the APM who are participating in CPC Plus, the scoring is driven by the larger group, by the shared savings will produce the scoring for those CPC Plus reports. As we said, the areas that will not be judged in these models are the CAPS survey and the hospital-based population health measures. You will not have to do a separate quality reporting or cost. You will have to submit your meaningful use measures. You will not have to submit your clinical practice improvement if you're a MIPS-APM. Okay, this is how CMS is weighting these categories in 2017. This will change every year, so you need to keep in mind this is only for this year. Shared savings, 50% of their scoring overall for the composite performance score comes from quality. You know, generally in 2017, MIPS providers is 60%, but if they're in shared savings, 60% of the score comes from quality, 30% from their meaningful use ACI, and 20% from CPIA, which is predetermined by CMS. CPC Plus has no individual weighting of quality. The people in the program have to report their quality, and they will be judged on it within the CPC Plus model. But that judging will not carry over to MIPS. So 75% of their score comes from ACI, meaningful use, and 25% from their practice improvement. Same with ESRD and oncology, same identical thing. They are not individually scored by their quality for MIPS. Next generation is treated like shared savings, and 50% of their score comes from quality. And the non-MIPS is treated exactly like you were a MIPS provider. 60% comes from quality in 2017. And your form of submission is really to your choosing. You will be reporting your quality into whatever format, and this is usually the CMS web portal for all these alternative payment models. And if that's the case, you continue to report that. You won't have to do separate reporting. Claims are judged the same as they always are by CMS on your claim submission. Your meaningful use measures and CPIA, if you need to report CPIA separately, which most of you won't in the MIPS-APMs, but should you need to do that, or meaningful use, it's your decision on how you report that. You can attest the way you've been doing. You can attest as a group. You can now push the information through one of the registries, through one of the specialty registries, or work with your vendor on it, or push it through the CMS web interface.
And you know, Cathy and I are huge on registries. The reason I personally like a registry is now you have to report on 50% of your overall patients. It's about finding the right 50%. So if you send 100% of your patients to a registry, they have logic to where they'll find the best cross-section of 50% of those patients and give you the best picture of yourself.
Okay, Medicare shared savings gives you 0 points if you perform under the 30th percentile. In MIPS this year, everyone will receive at least 3 points. So they start at the 30th percentile for their quality reporting. The improvement factor, don't worry about it this year. There is no improvement scoring for MIPS. It will start probably in 2018 where you get scored on how you improve. You know, we miss.
First question. It seems that CMS is encouraging participation in advanced APMs. If a small group of multi-specialists isn't already participating in an advanced APM, is there an opportunity to join or create one by 2017?
By 2017, no. I'd say that there's a special group in CMS that it's like a commission that's being used to set up new APM models for specialists, and they meet several times a year, and then they recommend new models to CMS. And what you've seen as far as the oncology care model and the ESRD are the first of those specialty models. There will be more coming out next year, but not in time for 2017 reporting.
Quite honestly, there are enough bonuses under the MIPS program that you will be fine.
Yeah.
All right, next question. We applied for MSSP, Track 1, and CPC Plus for right around 50 physicians. My understanding is that we will need to report for MIPS, but the quality score will come from MSP quality reporting, and we get full credit for CPIA, correct?
Yeah, CPIA you do get full credit for. You're right that the quality reporting comes from your MSSP, but as you could see from the slides, not every quality measure that you report on for MSSP is counted towards your MIPS score. So you can go back and review that slide just so you understand how they're weighted, but you're absolutely correct. They use exactly the same measures that you submit for the MSSP.
Please clarify comments around CPC Plus inclusion as an advanced APM. The Medicare CPC Plus program is an advanced APM. The Ohio Medicaid CPC Plus program is not an advanced APM because it doesn't have the technology requirement. There's a few other reasons, but it is CPC Plus is in, Ohio CPC is out. That was our last question. Let me check the chat box real quick. Well, folks, thank you so much for joining us today. This does close out our MACRA webinar series.
You all have a great day. Wonderful to talk to you all.